Thanks everyone for coming to this Outside In event. I'm really impressed that so many people could make it after staying up watching the Bernie and Hillary show. And thanks to those who are watching via live stream as well. Our Outside In series this year has focused on the challenges and opportunities surrounding the field of healthcare technology. And today's event is going to focus on chronic care delivery. We're going to be talking about how technology is changing the care of patients with chronic illness and what the future holds in those lines. And we're thrilled to have a really great group of panelists today. But before we introduce our panel to the stage, I'd like to take a minute to thank our partner Philips for their support of Outside In this year. And here to say a few words is David Schultz, Senior Director of Healthcare, Federal Government Relations and Policy at Philips.
Thank you, Arthur. Good morning, everyone, and on behalf of Philips, I want to welcome you to the Politico Philips Outside In series. This is the fourth in a series that we've had so far this year. We started off earlier this year by looking at the digital health and the pitfalls and the promise of digital health, and then next talked about the future of wearables, where the focus was really on the nature of the information itself and how important it is that the information be secure, that it be meaningful, and it be actionable. And our last series was on aging and aging in the home, where we kind of looked at the challenges that come from matching the technologies that have been developing with the opportunities and trying to figure out how we can improve the ability to care and age in the home. And it was in that conversation that Joanne connected the dots between chronic disease and aging. And I think pretty much led us here to this conversation this morning. And of course, chronic disease is a much bigger issue than just aging well. You know, it is the chief leading cause of death here in this country and accounts for about 75% of the $2.5 trillion in expenses we have. It's a topic of deep interest to Philips, where we've been partnering for the last 2 or 3 years with the Arizona-based Banner healthcare system, and have been working with them to develop what we call an intensive ambulatory care program that focuses on a telehealth program around the patient in the home that puts physicians and the patients in a collaborative basis with each other in near real time. And the results of this program have been very gratifying. 27% reduction in total healthcare costs, 45% reduction in hospitalizations. And it's we call it a high-touch, high-tech program that is really contributing to one of the reasons that Banner is one of the more successful accountable care organizations. So with that, I just want to thank Arthur and the Politico team here this morning again for the wonderful partnership we've had. This has been a very stimulating series this morning. I also want to thank the panelists who've come. Arthur and Joanne have again assembled just a tremendous, outstanding panel, and I'm very much looking forward this morning to a stimulating and thought-provoking conversation. Thank you.
Thanks, David. And now I'd like to introduce my colleague, Joanne Kennan, the health editor at Politico, and she's going to bring the panelists on.
I'm going to have a tablet on stage to take questions for the panel. And so for those of you in the room and watching over the live stream, you can join the conversation on Twitter. The hashtag is #OutsideIn, all one word, Outside In. And without further delay, I would like to welcome our panelists to the panel. Mike Payne is the head of medical affairs and chief commercial officer at Omega Health. Joseph Smith is chief medical officer, chief science officer at West Health Institute. Piper Sue is the Vice President of the Health Policy Division at the Advisory Board, and Ken Thorpe is the Chairman of Partnership to Fight Chronic Disease and a professor at Emory University. Arthur, you want to get us started?
So I thought we would start off by asking each of our panelists what they thought was the most easily accessible disease in terms of high-tech and health IT approaches. And so I'm going to ask Ken to start off.
Well, I would focus on obesity. And the reason to focus on that is that the share of adults that are obese has doubled since 1985, and that has just percolated into a whole range of rising prevalence increases of diabetes, hypertension, hyperlipidemia, obesity-related conditions. It's also a condition that we have interventions that work. Things like the Diabetes Prevention Program, other types of intensive diet and exercise lifestyle interventions that really can effectively deal with the problem.
Okay. Joe?
So as a cardiologist, I'd have to champion heart disease. I think we've already shown that you can take smart technology and apply that to folks who have rhythm problems in terms of heart rates going too slow with pacemakers, and now they're digitally enabled to give you information wherever you are about how you're doing. Implantable defibrillators, but congestive heart failure has been a recent example of how you can take smart monitoring technology and aid in the daily titration of medical therapy to keep people who are struggling with heart failure well and out of the hospital. So I think it's a pretty good rubric for what we can do with technology to manage a chronic disease.
Piper?
So I would say actually that it's probably difficult to pick one disease, knowing that the first population that we suggest providers target with their interventions are the people who have multiple diseases, right? So trying not to focus on just those who have CHF or just those who have diabetes, but looking across your cohort and identifying those folks at the very top of the risk pyramid. And usually those individuals are dealing with 4 or 5 conditions where the challenge is to come up with protocols that address all of their needs as opposed to just one disease specific. So we actually try to push people thinking beyond single disease interventions because the people who are going to benefit the most probably have multiple.
Mike?
I'm going to agree with Ken and Joe on this. I actually think obesity-related disease is the constellation of diseases that we should be focused on, and I think it speaks to both diabetes prevention or preventing progression of insulin resistance, and then also it's an integrated complex that includes progression towards heart disease. It's a complex of sugar pressure and lipids, and I think the technology gives us a chance in those obesity-related diseases not only to intervene but to actually change behaviors of patients. So I think we can affect patients across that spectrum.
You know, I wanted to make a sort of a thank you all for your answers. Piper, your company, one of the things that you do is you help doctors organize their panels of patients to figure out who needs the most intensive care. And that's obviously one kind of technology in this field, is sort of the organizing, crunching the numbers, putting all that data together, and then presenting it to a doctor, and basically the doctor is making the decisions and prioritizing the way that sort of doctors have done sort of from time immemorial in terms of triage, in a sense. I'd like to ask the panelists, do you think these kinds of technologies are what's key right now, or are apps and the kind of thing where we get patient engagement using either apps or gadgets in their homes that hold the most promise in terms of getting us forward? Mike, you want to start and go back the way we came?
Yeah, I mean, I don't think it's an either-or question. I think that the types of analytics that advisory board does, and we actually do this types of analytics at Omada Health too, to identify what patients need what type of intervention in as efficient a way and effective a way as possible. That's step one. And step two is then how do you actually intervene with those patients? And in some cases, apps will be part of that. Drugs will be part of that. Interactions with healthcare professionals will be part of that. In fact, interactions with other patients, sometimes in a group setting, face-to-face or online, will be part of that. So I think it's a constellation of different technologies, and that's probably the first step.
Mm-hmm.
So I'd agree it's a false choice to say it's one or the other, because we're going to have to do better at managing what are becoming critical resources in healthcare delivery for an aging demographic and a relative tsunami of chronic disease that's headed our way. I think the notion of doing a priori risk stratification and making sure that the limited resources we have are used on those who need it best and soonest, I think, is essential. Driving patient engagement with tools, clearly important as we're moving healthcare to the home, so we're going to ask people to be more engaged. But I also think we have to do this in a way that doesn't so much expand the footprint of disease in people's lives. We have to make technology a little bit more pervasive, a little bit more ambient, a little bit more automatic, because I don't think we can successfully compete for mind share of an aging demographic with a lot of gadgetry. I think we've got to make sure that it is sophisticated enough that it helps to keep people on the straight and narrow, oftentimes without their participation.
Well, clearly the innovation is there. I'm not so much worried about that. What I'm more worried about is the payment and reimbursement climate around that. So I think our biggest challenge is finding a way in fee-for-service Medicare to do two things. One is to really do care coordination in fee-for-service Medicare, and I think it's in a different way than CMS has been going. And second is to continue to transition out of fee-for-service payment so that we're not in the situation that we find ourselves with CMS now, that they're picking and choosing components and elements of what they're going to cover under telehealth, and really to have a much more comprehensive approach that gives providers and patients the flexibility to utilize different types of innovations in ways that make the most sense. So until we're sort of out of this picking and choosing modality of what's covered, what's not covered, and until we really do care coordination coverage in fee-for-service medicine, the innovation is going to be slower to develop than it should.
That's the huge topic, and that's something we kept in mind as we assembled this panel. But before we want to get there, I want to have a hypothetical patient in front of us, because I want to understand, and let's do a heart patient, because you're the cardiologist in the panel. And CHF is, congestive heart failure is common. It's a huge issue with readmissions. It is something we sort of, at least in the abstract, do know how to manage. It requires a huge amount of titration and monitoring because it is an erratic, people go up and down. All right, so what I'm trying to get a picture of is we've got like technology in the physician's office, and apparently you just told me that they have technology in their chest now, and I assume it's not like tweeting, but it's doing something. And then we have whatever the patient is doing their own input, self-monitoring or using, or has something on their wrist or whatever. So like how much technology is circling around this patient with a heart problem? And yeah, I know she's also got diabetes and rheumatism, but let's just talk about her heart. We've got an 85-year-old CHF patient with who's in this cyber aura of technology and medicine. What is coming at her, whether she's engaged? What does she have to do? Sort of give us that picture, and then we'll figure out how we pay for it.
So I can start. I think you've alluded to a problem that is near and dear to our hearts in terms of trying to make sure you don't have multiple silos of information that where no one can benefit from the integrated whole because it never gets integrated. And so I think there's a desperate and pressing need for interoperability so that all of that information can flow seamlessly to a form of decision maker, and we have to talk about that. I mean, I think there's been an awful lot written and said about how all of this information needs to find its way back to the managing doctor, who is already overwhelmed with ICD-10, which just gave them 70,000 ways to describe how their patients are sick, and 21,000 different medicines, and more guidelines than they can consume that are updated more often than they can stand. And so the notion of giving them streaming information on every patient they take care of that measures blood pressures every 3 minutes, that's just not workable. And so we need more automatic, connected, and coordinated use of technology to drive kind of knowledge and insight as opposed to data and recognition. And so I think we can do it. I don't think we're all the way there, but there are really good examples, right? So in congestive heart failure, there's an approach now for dropping off a relatively modest intervention that leaves a sensor behind that information is sent back to a nurse coordinator who then can help that individual as they integrate up their blood pressure and their weight and their measurements from inside their chest to say, you know what, we need to augment your medicine a little bit. And that keeps people out of the hospital.
And how is that communicated? So there's a sensor in her chest that's not telling her anything. It's just there. And when she hits in some red zone, there's an alarm that goes off, there's something that shows up in her EHR. How does that happen?
So that's telemetered back to a coordinating nurse who then, with a treatment protocol previously defined, can give an intervention back to that patient. And so
and the nurse, the patient doesn't have to get up and call the nurse. The nurse
Right.
is going to track down the patient.
And we have to do it that way.
You need to change your Lasix.
We simply can't burden the sickest with the job of integrating up the most complex. That's wrong-headed.
So it's not this. I mean, one of the models that's been used in readmission, and this was maybe 7 or 8 years ago, it was that was the technologically advanced thing at the time, was the patient gets up, answers patient or their caregiver weighs themselves, answers 4 or 5 questions about weight, breathlessness, et cetera, and if they have more than 2 yeses, they're supposed to call a nurse. So this gets rid of that, trying to assess, am I breathless or not today? What did I weigh yesterday?
And all of these streams of information can play together if we do it right, so that we can prompt people when they need to ask and answer those questions. So we can start to integrate up how they're feeling with as well as the objective data that we can get. I think there's a tremendous opportunity. We're just not exploiting it yet.
And in sort of that both several you talked about diabetes and obesity. So getting in downstream before they've got severe out of control diabetes and they're in a coma, if they're still in the sort of dangerously pudgy stage, I mean, then we talk about wearables, and they're very popular, they're sold, but people wear them for 3 weeks and then they end up under the bed. So where are we going from transitioning that to sort of acute tech gadget to a tool to truly keep us healthy in a way that is integrated with our caregiver system, with our physician, with our hospital, whatever? How do we go from, and I don't want to pick on Fitbit as a brand, I mean, how do we go from keeping that Fitbit being useful information to get less dangerously pudgy to, how do we make it a medical tool? And maybe, Mike, you want to talk about that?
Sure. Yeah, I won't pick on Fitbit, but I will pick a little bit on MyFitnessPal. There was an interesting study that came out in Annals of Internal Medicine November of last year that basically looked at MyFitnessPal versus a control group, and what it found was there was no weight loss or healthy behavior improvement in the active arm. And that was basically MyFitnessPal by itself. And I think in general, I would say the chronic disease community is coming to terms with the fact that data by itself does nothing. It's necessary but not sufficient. And so the idea that you need to put together data with the appropriate kind of behavioral intervention, if you want to call it that, we call it behavioral medicine, is incredibly important. And the key is you have to actually get the patient to want to engage not only with the device and their health, but with the behavioral intervention. So I think a lot of the device companies like Fitbit, Propeller Health out in California, Livongo, who does smart diabetes devices, they're coming around to the idea that you have to pair these devices with behavioral therapy. And that's where the work that Omada Health has been doing in terms of group-based behavioral therapy is helpful, because it's the behavioral therapy layer that needs to be paired with these types of smart devices. It's got to be the combination.
But do you even use, do the people in your programs even use, are they assigned a Fitbit or a Jawbone or whatever? I mean,
yeah, there's a couple
there's
a couple of devices that we use. We actually use a connected scale, cellular connected, because not everybody can pair a Bluetooth or a Wi-Fi scale. And weight, whether we would like to think of weight as a good clinical indicator, weight loss has been much maligned, but at the end of the day, if you do weight loss correctly, weight loss mediated disease risk reduction, that is a very important part of the equation. And so having weight readings for the majority of people in our society who are overweight and obese, that's an incredibly important part of management.
So the high-tech tool known as yield weight scale.
Yeah,
scale.
Yeah. I mean, it's old tech, but it's important. We do use. We allow patients to integrate their Fitbits or their Fuel Bands or their M7 chip in their Apple device into our platform too, so that our health coaches can see it and they can see their trends.
And how does that work for, I can see that working for a younger, healthier population at risk that is tech savvy. How does that work for somebody with the patient Piper described, an older patient with 8 chronic diseases and maybe a little not so sharp as they might have been? How can you do that with this? Because they're the expensive people. Now, obviously, if we get prevention right, we will have fewer. I mean, eventually everybody will get sick, but we'll have fewer of those really expensive for many year dual eligible types, right? So who's your target for the model you just discussed?
I mean, the ironic thing for the behavioral therapy that we do is seniors actually do better than younger people in our program. And I think part of that is we've made the program easy to use, but it's the Pew research on internet use in seniors. It's in the 60% now that have a broadband connection or a smartphone. So this fallacy that seniors aren't accessing technology is just not true. And in fact, everyone talks about the digital divide. For us, we see kind of an analog divide, where you have these therapies and that people need to access, but they're locked in their home or they're busy. They just don't want to access them. The Patient-Centered Medical Home initiative from CMMI is a good example, where patients are interacting with technology in their home, and that's for more acute patients. We kind of view what we're doing as patient-centered medical home for people that don't need to stay at home all the time.
Well, and I would say that that's why I think it's important that there's no one-size-fits-all model. You really have to think about the way that you are able to put data back into either a provider's workflow or a case manager's workflow or even a patient's workflow, because for some patients there's a technology approach that's going to work well. For some patients it's going to be the one-on-one relationship with a care manager. For some patients they're going to take the best direction from their physician. And so you really have to be figuring out, I've got all these data points coming in, patient-generated data being one of many, a very valid one, but one of many. And then how am I pushing that back out to multiple points so that I'm touching the patient in the way that they are going to be best in responding to? And that means that you have to be looking not just at mobile applications or one particular intervention, but a multitude of interventions so that you can match them to the patient and have the highest degree of effectiveness.
Ken, you seem to.
Yeah. All these technologies are great tools, I think, to help enhance both prevention and care coordination. I just want to take a bigger step back and really think about some of the structure you need, though, to really make a difference here. And the good news is that we have some great examples of programs that actually have been very effective and work. On the prevention side, so the diabetes prevention program, which I've talked about before, we have a decade plus of data that shows that it does a good job of preventing the rise in diabetes and other chronic conditions. And that's particularly important for Medicare, since half the Medicare population are pre-diabetic. On the care coordination side, even more fundamental than some of the sort of evolving technologies to really make this work is having electronic health records available to the care teams as well as the physicians, primary care practices, the hospitals, and so on, so that they're populating the same medical record at the same time. So until you have that real basic infrastructure in place, it's kind of hard to really do this effectively. And the place that I've been working the most on this has been in Vermont. RTI mathematical evaluation of that program has shown that Medicare got a 5-to-1 ROI in terms of savings using those community health teams in Vermont. And a lot of it is because of the technology, having the health records in place, doing sort of the ongoing evaluation, monitoring of the population, really having weekly feedbacks with the care coordinator and the provider practice. And the fundamental part of that really was the electronic health record.
Mm. I'd probably add one thing. I think we're in a bit of an awkward time when we're looking at, as we look at technology around this issue of chronic disease, we've watched kind of an explosion of technology-driven development, and we're still waiting for the design of full-on solutions to catch up. And so we're still confronting sometimes sick patients with under-sophisticated technology that provides them as much challenge as opportunity. And I think what's waiting is the notion of integrated systems approaches, where we let design catch up with the technology that we've enabled, and we start to provide solutions that are more user-inspired than we have. And so I think, as is often said, the Fitbit goes under the sofa cushion after 3 weeks. I think that's not a failure of the patient. That's a failure of the technology to be adequately sophisticated, and a failure of the system to integrate up sophisticated technology to give an all-in solution. So I think we're at an awkward time, and I wouldn't want to taste this cake before it's fully baked. I think there's a tremendous opportunity.
I want to quickly build on that. I think our perspective at Omada is that there's a new capability that's needed in healthcare, and that's what we call user experience design or behavioral design. right? And it's a completely different discipline than we've had in healthcare before, and it's thinking about the human factors of interaction with your disease, right? All the little things that cause you to make maladaptive choices and have maladaptive beliefs. And so like we actually employ a whole bunch of user experience designers from the kind of consumer world, and bringing that type of human factors thinking into healthcare, I think, is what allows you to have a systems level view of how to do treatment, but do so in a way that's delightful for the patient.
Right.
In such a way where it's actually enjoyable to interact with healthcare for the first time.
Yeah, when has healthcare been enjoyable?
Yeah.
Right. Well, yeah.
When Arthur and I do panels.
Yeah. Well, right. I mean, I was at a panel yesterday, and someone was talking about that you could make the experience of finding a assisted living facility for your parent delightful. And I was thinking, no, you can't. I don't care how good the technology is. But anyway, aside from that, I mean, we're expecting that these tech developers, out in Silicon Valley or wherever they are, to come up with these great devices that are more user friendly and so on. But the idea is also that they won't be incented to do that unless people are going to buy them. And part of the way that we're hoping to buy them is that they'll be incorporated into, Medicare reimbursed care. So you guys want to take that on, and sort of what's currently working? I mean, CMS does have various programs. What's currently working? What do you see as sort of the future for? If you were, the head of CMS, the CMS administrator, where would you be taking this up? Ken, why don't you start?
Well, I'd probably do three things. I would sort of transition very quickly from a piloting mentality. So I've been saying for a while, I have pilot fatigue, into one that we're actually implementing things that we know that work. And so there's three things that we know that work that Medicare doesn't cover. One is intensive lifestyle programs like the DPP. That should just be introduced into Medicare tomorrow morning. That would make an enormous impact on the program.
Can you spell that out, the DPP?
Diabetes Prevention Program. Second is that we should give some serious consideration to the recent wave of FDA-approved weight loss medications, just to give clinicians and families a broader clinical choice of how to deal with weight loss. That's not covered. Third is that I would move into really doing care coordination into fee-for-service Medicare, and really using these health teams to work and collaborate with providers to do transitional care and medication therapy management and health coaching, things that we know that are effective components of working with patients. And I guess the last thing I do is I really would accelerate the transition away from fee-for-service, because really until we get to a situation that we have a reimbursement environment and a payment environment that allows innovation to really flourish. I mean, these apps will come out of the woodwork. I mean, I'm no concern about the private sector developing applications that would enhance the use of technology in managing patients. We need to change the payment, care coordination, and prevention environment to do it, and then we'll have an explosion of innovation and technology out there to really enhance the patient's experience.
Before we get to the other panels, you talked about the Vermont model where they've implemented this in Medicare and that they have a 5-to-1 ROI. How is that in a non-fee-for-service? Is that in an ACO? I mean, what's the economics of that program, and how they know they're saving the money?
Well, it's an interesting model because it's a model that all payers use. So Medicare, Medicaid, the private sector, all rely on these health teams to manage their patients. They all chip in, so that the team members are all salaried. The providers that interact and use the teams are paid a per member per month payment to work with them. There are uniform quality metrics to measure how well the patients are doing. And what they found is that over time, that not only in Medicare, but in the commercial private sector, Medicaid as well, that it's cut the rate of hospitalizations down very substantially. So it's an opportunity for physicians, providers, health clinics, ACOs, to really have the prevention and care coordination capacity that once that patient leaves the physician's office, that there's a handoff that says, here's, nurse so-and-so is going to follow up with you on the care plan. We want to make sure that you've filled and refilled your medications, you understand the care plan, that you're monitoring your vitals. You can use some of the technologies at that point to do the monitoring. But it's just building the infrastructure. And the thing is, we don't have that infrastructure in a holistic way for the most part, in Medicare in particular, because we don't pay for it. But this was a system that paid for it, and it was enhanced because the state also paid for electronic health records that the teams had, that the practices had, that they could provide ongoing information and monitoring of how well the patients were doing.
I want to go back to a point that Ken made about the diabetes prevention program. I mean, just to be really clear, if you are a senior in this country on fee-for-service Medicare, and there's 35 million or so of them, and you go to your physician and you get diagnosed as a new onset type 2 diabetic, you can get prescribed and get reimbursed for drugs, devices, diabetes self-management education, a whole host of stuff. If you're diagnosed with an HbA1c or a fasting glucose that's a point lower and you're pre-diabetic, the most that the doctor can do is tell you to come back when you're diabetic, right? And yet we have this intervention that for 10 years has been shown to work to prevent progressing to a condition that's 2 to 3 times more expensive on average than being pre-diabetic. And it's just insane that CMS is not reimbursing for something that works that can prevent future costs.
So when an AMA person told me that this is something we really know what works and it's not being widely adopted by physicians, it's because there's no way to pay for it. That's the...
Well, I mean, yeah, CMS is new to the prevention game and new to the chronic care game, right? The chronic care management codes that CMS lit up earlier this year, that's a very new thing. And there's some data that came out yesterday that only 20% of physicians are using the chronic care management codes with their senior patients. And part of the issue with that is they don't know how to use them.
And what about the under 65? Because you can be pre-diabetic at 58 or 62 or 29. I mean, is there...
This is the amazing thing, is the diabetes prevention program is actually it's not everywhere amongst the under 65 commercial population, but there are a lot of commercial plans that are reimbursing now for diabetes prevention programs, and it's heading in that direction. And in fact, the U.S. Preventive Services Task Force provided some guidance late last year that basically mandates commercial payers to cover programs like the DPP. So it's clearly headed in that direction on the commercial side, and CMS is just lagging.
And is that integrated into workplace? And then in the commercial side, is that because employers want it, or is that just the health plans are doing it?
Employers do want it for 2 reasons. One is there's a lot of kind of presenteeism, absenteeism, safety event impacts of obesity and related conditions. And the plain fact of the matter is if an employer offers a program like the DPP to their employees, they get better loyalty, retention, satisfaction as employees. So we're doing most of our business through those self-insured employers.
I want to go back to the point, that around how incentives really matter. And this notion of moving from volume to value that everyone talks about. As soon as you put systems of care at risk for the management of their patients, this notion of moving quicker to adopt things that really work becomes under local control as opposed to under the control of the central organizing body. And so what you then enable are people just to show that something works, and then you get to go. And I'll give you a concrete example. So in full disclosure, I sit on the board of a company called Reflection Health, and they said, you know what, it's kind of crazy that people who get their joint replacements should have to find their way back to physical therapists to get their post-op physical therapy. Why don't we enable that at home using smart technology, really cool, using the Microsoft Connect platform to measure how people are doing in 3 dimensions and give them an avatar that gives them feedback and just have that work. And it looks like that pulls a lot of money out of the system, and it allows patients to get what they want at home. It's completely directed in the right direction, and then CMS comes out and says, you know what, we're going to bundle this up. We're going to make this at risk, and that's a huge tailwind to those efforts. And so I think if you can free up the reimbursement mechanisms to allow individual systems of care to do what they think is best, and then you enable them with tools that are good at risk stratification, I think we can all move forward a good deal faster. But if we're going to stick to central planning and we know what's best, I think we're going to be mired in a very slowly moving system, and that's not what we need.
Yeah, I was just going to say, I think that sometimes these specific program reimbursements are somewhat an interim step, right? Because what you'd like to get to is the point where it doesn't actually matter if Medicare specifically covers one particular intervention,
Right.
that you're in a risk-based payment environment where you're making your own determination in terms
Absolutely.
of what is the right treatment for your patient, and you have the payment and program flexibility to implement that with credibility on the back end. So you're still being held for accountable for quality and all of those aspects, but you do have the flexibility, and that's how providers want to practice, right? So we've talked a lot about improving the patient experience through technology. It also has the side effect of improving provider experience, right? Providers becoming more engaged with their patients, feeling more empowered that they can do what they want to do without worrying if this fits within a particular code or if this particular intervention is going to be covered. That's the type of environment that you'd like to get to. Now, interim steps are very important because that transition is going to take work, and it is largely built upon a technology infrastructure, because if you don't have the information you need to make those decisions, then you're just throwing out resources without sort of any accountability or efficiency. But it really is moving towards a more risk-based accountable payment model that I think is ultimately going to end up with a big boom, as opposed to putting resources into specific programs, which
Right.
you know are truly interim steps, hopefully, as we move to a more sort of flexible and accountable healthcare system.
And is Darius, where are you, Darius? You're here? We have a reporter. One of our eHealth reporters, Darius, who I'm still not seeing. Do you want to, oh, there you are. Now I'm seeing him, right?
Stand up.
You want to throw in a question?
Sure. There's been some commentary around the diabetes prevention program. I know there's been some controversy surrounding its effectiveness, and I was wondering what you guys thought of some of the scientific scrum about that program.
You brought it up.
Yeah, I brought it up, okay. Well, I mean, we have, there's sort of two types of data and evidence on it. One is that we've had, a long-term randomized controlled trial where we have at least 10 years of data following patients that show a cumulative reduction of diabetes incidence of 34%. But I think more relevant is what's been happening nationally with the YMCA of the USA, who have really rolled this program out, not completely nationally, but certainly almost nationally, in conjunction with some health plans like United, increasingly some Blue Cross plans as well. And their data are showing very similar results. The average weight loss goals in the diabetes prevention program was something on the order of 7%. The actual real life replication of this model that the YMCAs have been doing are showing data that are in the 5 to 7%, very similar reductions in weight loss. So, I think we have a lot of community-based evidence and data from what the YMCAs have been doing, and increasingly being adopted by some private health plans that show the efficacy of what's going on. The private sector, as we were talking about, is just ahead of the curve on this. They're integrating it into their benefit designs. It's I think, an important part of workplace wellness programs as well. And it's one of those things where CMS certainly has the authority to roll this thing out nationwide, just like they've done with the bundled hip and knee replacement program. It's something I think they should just do, as I mentioned, tomorrow morning.
Just to add to that, there's the large randomized controlled trial that Ken mentioned. The Finns, the Chinese, the Brits have done large-scale studies with the diabetes prevention program model. All of it shows the same results, that it does reduce weight significantly, biomarkers significantly, and reduces the incidence of diabetes very significantly. And furthermore, from a cost-effectiveness perspective, the Community Services Preventive Task Force this year released a meta-analysis of health economics around DPP, basically showed that it's cost-effective, or in some cases cost savings, at an average of about $1,800 per quality-adjusted life year. So you think about all the stuff we spend money on in healthcare in this country, $50,000 tends to be kind of the threshold for is it cost-effective or not. This is highly cost-effective compared to other healthcare interventions. And now, I think in general, the community is thinking that it's not a question of is it clinically effective with a single patient, it's is it scalable to the 87 million pre-diabetics in this country. That's an operational challenge, and I think the YMCA is doing a good job providing nationally this program in a face-to-face setting. and Omada Health, our company, is basically doing the same thing, delivering the diabetes prevention program virtually. And at this point, the YMCA and us are the two largest DPP providers in the U.S.
And I think the savings are probably a little understated. I know, and I know the politics of the different disease groups.
Yeah.
You know, this is called the Diabetes Prevention Program. This is really the chronic disease prevention, prevalence reduction program,
Yeah.
because obviously the weight loss that is accompanied with this intensive lifestyle intervention not only reduces the prevalence of diabetes, but it has a big impact on blood pressure, lipids, associated mental disorders. So the potential cost savings from this are much greater than just simply the diabetes incidence reductions. It really affects the broad range of weight-related chronic diseases.
But I think this is the right conversation to have, right? So as one moves away from doing what we've always done because we can make what we've always made, the notion of saying, I'm going to do something because there's an ROI that's been demonstrated, because I believe in the data. You know, it's this whole area of digital health has been one where it has made sense conceptually, but now we're at a phase where we're asking people to, you know, in God we trust, but everyone else has to bring data. And so please show me that this actually works. And asking questions about effectiveness or cost effectiveness, that now is a valuable part of the conversation which was absent before. And I think it's the right conversation for us to have.
Piper, what are you hearing about, we talk a lot about patient compliance, but using new tools also requires physicians to think differently. And they are, as Joe mentioned, they're overwhelmed. I mean, there's just this torrent of new stuff coming at them all the time, new requirements, new tools. How, you know, when you know, advisory boards going into a system or a group practice or whatever the venue is, do they just sort of say, oh, another one and shut down, or they say, oh, fine, you know, I'm ready for the next thing? I mean, what are you know, I always say that healthcare reform is partly anthropology, you know, like making doctors the tribe change. So what do you see there?
Yeah, I mean, I think the first thing we always say is that the cultural change is the most difficult, right? And physicians have in recent years had a lot of things pushed at them, right? So they know that they have electronic health records now. They've spent a tremendous amount of time learning how to use them, and they're getting frustrated because electronic health records are, as Mike said earlier, necessary but not sufficient, right? Because then you also need a tool that takes all of that information, pulls out what's most important, and makes it actionable in a very user-friendly way, both for the physician and for the patient. And I think, you know, the stage that we're at right now is trying to figure out how do we make that actionable. And that's really about how do I present it in workflow. I don't want to give them too much information such that they're getting fatigue, but I need to make sure I'm getting them the essential information so that they're not missing big episodes. And I think right now, you know, that's part of the really interesting piece of innovation, is that you've got a lot of different models competing in this space in terms of who can make the most user-friendly interface. At the advisory board, we have a highly customizable dashboard interface that literally looks like your car dashboard that we designed with physicians, trying to get at a model that physicians would feel comfortable using and would be willing to utilize. But, you know, some of the fun that we're going to see in the next couple of years is innovative approaches to that, whether it's through a behavioral approach or through a technology approach, in terms of how do we take all of this information, and we're getting more and more every day, pick out what's important, and then put it in front of somebody in a way that they can actually use. And that's much easier said than done.
I just want to throw in one last curveball, which is, Mike, you and I have talked about the issue of sort of security and privacy in this area. And I mean, how is that going to affect the entry of different, you know, tech companies or people who are trying to use tech in managing this?
Yeah, sure. You know, last year, Chuck Schumer kind of jumped all over Fitbit for the potential for, you know, privacy issues, because at that point Fitbit was not HIPAA compliant. And also, you know, there were concerns about whether or not there would be selling of data. And I think we're having this panel at a timely moment because, you know, Fitbit a few weeks ago basically announced that they are now HIPAA compliant. And so I think that, you know, in the Valley, there's a growing awareness of the importance of security, and that's by necessity, of course, in the wake of the Anthem and Primera and OPM breaches. You know, our types of customers, pardon me, health insurers and self-insured employers are really holding companies like ours to very high levels of information security. And in fact, the venture money that we've raised at Omada, a good portion of that is going towards building a security infrastructure that looks like the security infrastructure of a 5,000 person company, not a 200 to 500 person company. And so I think what's happening is, Silicon Valley companies realize that the Silicon Valley mantra of, fail and learn from it is not going to work in healthcare. We got to get it right the first time. And so that, I think, is going to change the funding model for digital health companies. I think it's going to lead to bigger rounds of investment. And I also think it's going to lead to, an increasing expertise in digital health companies around information security. And it'll separate the companies who are really serious about big iron healthcare from those who just want to take a consumer approach to wellness, if you want to call it that.
Questions in the room? We got one back over here. Can you identify yourself?
Hi, Dan Hoff, Health for America Fellow. I guess I have a question. So we talked a bit about chronic care as it applies to senior citizens. A huge problem with chronic care, however, is that it develops earlier when people are lower income or kind of underserved. So I wondered if you guys could talk to that aspect.
So I'll say one thing about that. So we have a focus on successful aging and have put up in San Diego a senior center where we try to take folks who are living at or below the poverty level, give them food as an opportunity to bring them together, give them services, and are integrating health into that, and are putting up a dental clinic because there's a big gap in dental and mental care for kind of under-resourced seniors. It's an enormous challenge, but I don't think it's unmeetable. I think you can meet that if you design systems appropriately. It's not giving every senior a Fitbit. It's not going to be the answer. But it is providing wraparound coordinated services, integrating up community services, and creating a bit of a Chinese menu of what is the best thing that you need the soonest in order to give you food security and housing security, and integrating up healthcare into that. We have our work before us is to try to show that there's an ROI on that, and that can be sustainable and reproducibly scalable across other places. But that's some of the work that we've taken on.
I think that's one of the reasons why these health teams were so successful that you're pointing out across the board, low-income populations, young populations, older populations, because they not only provided medical care coordination, but they provided a range of social services and integrated social and medical care services, because a lot of the problems that you find in terms of compliance and issues facing a whole host of populations is not necessarily medical, but it is what's going on in the house, what's going on at the home, making sure that people understand the right diet regimen, and so on. So, I mean, if you're going to really, I think, do this right, we've got to get out of a sort of narrow medical model and really think much more broadly about how to integrate social services that really could address some of these problems, particularly with low-income populations, along with sort of the traditional medical care coordination functions.
Yeah.
I'm sorry.
No, go ahead.
One statistic, real quick, that I think puts this in context is we often talk about how we spend more than any other country in terms of healthcare delivery. Compared to the OECD countries, we're besting them in every variable except for outcome. When you look carefully, though, you see that we only spend 55 cents on social services for every dollar we spend in healthcare, and the average in the OECD is $2 in social services for every dollar they spend in healthcare. We're trying to solve social ills with medical tools, and guess what? It costs too much money.
Yeah, I would say there are probably two pieces that I think it's a very important piece, and two things to consider. One is that you have to really be building the recognition of that issue into the technology and the tools that you're using. So, for instance, in our technology, when a provider assigns a patient a risk score, 50% of that risk score is based upon their claims and EHR data, their clinical conditions, and then 50% of that risk score is based on a psychosocial survey. So do they have access to reliable transportation? Do they have financial copayment issues? Do they have in-home support? Asking all of these questions to try to get at those issues and incorporate them in the care plan from the very beginning, and that's critically important And one of the other pieces of that makes that possible is that as we're building our health information technologies, we have to be building them in a way that they can integrate not only in a medical community, but in just the community in general. And that means building portals and other tools so that those organizations can feed information in and extract appropriate information out. And that's relatively straightforward to do. You can build certain permissions, you can allow different types of information sharing, but you have to be doing that if you're going to get at an accurate risk assessment profile so you know where to allocate the resources.
Mike, you have a quick response, and then I have a very good Twitter question, and we'll head toward wrap.
Yeah, if I can build on that, I think it's really important that we set the expectation for digital health companies that they invest in that area. I come from biotech and pharma before I came into digital health, and much maligned sector, but at the end of the day, pharma does a pretty good job of providing low-cost drug to uninsured and underinsured patients. And I think that the digital health community has to do the same thing. We're doing clinical trial work in Medicaid and safety net patients out in California to prove the model with our intervention with those folks. And I think we have to hold companies to doing clinical trial work broadly defined, right, in addition to information security. So any digital health company that's out there should be doing clinical trial work and getting it published in peer-reviewed journals. That's another thing that leads to higher venture costs, but that's okay because it provides the proof. And we should hold them to the standard of doing that in needy populations.
And a quick response. This is a good question from Twitter, which is, we have this enormous infrastructure or system now, quality measures and quality incentives, and without getting into a 5-hour discussion about how complicated that is, are there some good metrics that are driving uptake of some of the tech solutions that you're talking about, or are we on sort of two parallel roads that aren't intersecting?
I don't think we should have quality measures unique to adopting technology. I think we need quality measures that are focused on outcome and let the individual providers solve the delivery needs with a technology that's proven to be appropriate.
I do think that, and we were talking about this before the session, that when it comes to prevention, and that's a core concept in chronic care, we often equate quality metrics for prevention to screening. Right? Prevention is screening, and that's just a fallacy, right? You have to screen, but then you have to treat. And it doesn't always happen. Oftentimes you screen and then the treatment plan is not provided, or the right provider in the care team is not engaged. And so we have to broaden our quality metric definition of what prevention is.
I think on the quality metrics, I think we probably need to do two things. One is that we need to simplify and streamline.
We don't need 1,000?
No.
Yeah.
But secondly, I think
That would be welcome.
we need to do some real rethinking of how we're measuring these outcomes, because I think that the tendency on these quality metrics is that we do these disease condition by disease condition. And the bottom line is that a typical patient out there is a hypertensive diabetic with bad cholesterol, asthma, back problems, and is depressed. And so we need a measurement that recognizes patients with these multiple chronic conditions that's not just sort of looking individually at each specific metric, but really is doing a much more comprehensive look at that particular type of patient. And we don't have those metrics in place right now.
Piper, last word?
No, I would just say, I think we're at a relatively rudimentary stage when it comes to quality measurement, and the first step is just getting to outcome measures, right? It's simplifying and streamlining, and then actually having meaningful measures that are measuring something that's altered in the individual's health as opposed to just something that you're ticking off in the exam room. And we're still in that period, but if we can even get there, I think that's an awfully good start.
I'm going to hand off to Arthur in a second. I just want to, my sort of takeaway is I came here thinking we were going to talk a lot about connections between phones, what we have in our phones, and our physicians, and that those were our tools for monitoring chronic disease. And I came away seeing that it's a much more complicated sort of technological ecosystem of data coming down as well as data coming up, and some of which will be automated.
Right, and I think that very great discussion, and I think the point is that what we've heard today is that the technology is only, it's great that we have this new technology, but we have to know how to use it in the best ways, and it's always going to be people who are, and the larger context that these technological tools are relevant in, and so it'll be interesting to see how these things develop. So thanks to all of our panelists, and thanks to Philips, the sponsor.
Twitter chat?
Yes, we're going to have a Twitter chat next Friday. That's October 23rd with the hashtag #OutsideIn.
I would really welcome physicians who are using these things and patients as well to join that conversation.
Right. right? So hopefully we can broaden the discussion. And thanks to everyone on the panel. It was a very great discussion today.
Thank you. Thank you.